हेलो गुड मॉर्निंग फ्रेंड्स एंड आज हम डिस्कस करेंगे कार्सिनोमा पेनिस. बिफोर स्टार्टिंग I'd like to thank Chandana Shri Ma'am for sharing the wonderful notes with us, and the link for the notes is given in the description below. You can download it from there, and these are very helpful notes for studying fast and quick revisions. And let's get started. So carcinoma penis, we'll see the epidemiology. So it is commonly seen among old men, and it has poor prognosis. With 65 plus is the common age of diagnosis, and at diagnosis there is lymph node positive commonly, and it is increasing in the non-circumscribing population and is rare among Jews. So what are the risk factors? Risk factors are poor sexual habit like multiple sexual partners, phimosis, balanoposthitis, that are some common issues of the penile region, chronic penile inflammation due to infection, lichen sclerosis, that is balanitis xerotica obliterans, smoking and tobacco, common infections like HIV, HPV, of which 18 and 16 being most common, and having the RBNP53 gene mutation, then poor hygiene, lack of neonatal circumcision. These result in smegma formation, which is associated with high chances of penile carcinoma. Then we have penile trauma. So we'll just quickly revise कि बंदे की सेक्सुअल हैबिट्स खराब है, मल्टीपल सेक्सुअल पार्टनर्स इन्वॉल्व करता है, फाइमोसिस है, अनेबल टू रिट्रैक्ट प्रोप्यूस, इन्फेक्शन है बैलेनोपोस्थाइटिस ऑफ द ग्लैंड्स ऑफ द प्रोप्यूस, देन क्रोनिक पेनाइल इन्फ्लेमेशन, वहां पे इन्फ्लेमेशन हो रहा है पेनाइल रीजन में लंबे समय से, लाइकेन स्क्लेरोसिस, वहां पे फाइब्रोसिस हो रहा है तो बैलेनाइटिस जेरोटिक ऑब्लिटरेंस, देन स्मोकिंग एंड टबैको, इन्फेक्शन HIV एंड HPV जिसमें से 16-18 ज्यादा कॉमन है, पुअर हाइजीन एंड लैक ऑफ नियोनेटल सर्कमसिजन जिसमें स्मेग्मा जमा हो रहा है पेनाइल रीजन में, एंड पेनाइल ट्रॉमा. Now we'll see the pre-malignant lesion for penile cancer. Some are HPV related and some are non-HPV related. So what are the non-HPV related? That is cutaneous horn, then pseudoepitheliomatous, keratotic, meniscaceous, balanitis. Then we have BXO, that is balanitis xerotica obliterans. So we'll see each one in short. Cutaneous horn, these develop over a pre-existing lesion. जहाँ पे एक पहले lesion है वहाँ पे develop होता है, ठीक है, और विच में भी प्री मेलिग्नेंट. तो उसको क्या करते हैं, रीएक्साइज करते हैं, मार्जिन जो बेस है उसको एग्जामिन करते हैं, और 33% चांस होता है उसमें 80C होने का. देन PKMB, दैट इज सूडो एपिथेलियोमेटस केराटोटिक मेकेशियस बैलेनाइटिस, ठीक है, ये ग्लैंड्स पे ग्रो करता है, प्लेक से वेरुकस, और वहां से इन्वेजिव फॉर्म ले सकता है. देन VXO, दैट इज बैलेनाइटिस जेरोटिका ऑब्लिटरेंस, जो कि जेनाइटल लाइकेन स्क्लेरोसिस है. व्हाइटिश पैच ऑन प्रोप्यूस हो सकता है, ठीक है, ग्लैंड्स, मियाटस, फॉसा नेविकुलरिस, ये सब इन्वॉल्व हो सकता है. ट्रीटमेंट क्लोबेटासोल ऑइंटमेंट, दैट इज अ स्टेरॉइड, एंड मियाटोप्लास्टी और एक्सीजन, ये ऑप्शंस है ट्रीटमेंट के लिए. देन HPV रिलेटेड क्या क्या है, तो कॉन्डोलेमा एक्यूमिनेटम, बश्को-लर्नस्टेन ट्यूमर, दैट इज जायंट कॉन्डोलेमा एक्यूमिनेटम, एंड बोवेनॉइड पैपिलोसिस. अब इसको इंडिविजुअल देख रहे हैं तो कैंडोलोमा एक्यूनेटम क्या है, सॉफ्ट पैपिलोमास रहते हैं, HPV 6, 11, 42 एंड 44 इन्वॉल्व हो रहे हैं. इमिक्वेमॉड एंड सिडोफोविर जेल 5-फ्लोरोयूरासिल क्रीम, ये यूज करते हैं इसमें ट्रीटमेंट के लिए. बश्के-लोवेंस्टाइन ट्यूमर में जायंट कॉन्डोलोमा एक्यूमिनेटम, जिसमें टॉपिकल पोडोफाइलिन या 5-फ्लोरोयूरासिल ट्रीटमेंट के लिए यूज कर रहे हैं. देन वी विल कम टू पेनाइल इंट्राएपिकल न्यूक्लियस और कार्सिनोमा इन सीटू. इसमें ग्लैंड्स में जब इन्वॉल्व होता है तो उसको बोलते हैं एरिथ्रोप्लेजिया ऑफ क्यूरेट, और शाफ्ट में जब इन्वॉल्व होता है तो उसको बोलते हैं बोवेन्स डिजीज. अभी प्रेजेंट कैसे करते हैं जनरली, मोस्ट कॉमन साइट क्या है, ग्लैंड्स, प्रेप्यूस, कोरोनल सल्कस, देन शाफ्ट. स्मॉल लीजन होगा, फिर वो स्प्रेड करेगा आसपास, लाइक ग्लैंड्स, शाफ्ट, कॉर्पोरा. अनरिलेटेड, अनट्रीटेड में पेनाइल पूरा ऑटो एम्फिट हो जाएगा. लीजन कैसा हो सकता है, तो पैपिलरी, एक्सोफाइटिक, और फ्लैट और अल्सरेटिव, ये दो है, और सराउंडिंग रीजन में इंड्यूरेशन रहेगा. तो जो फ्लैट और अल्सरेटिव है उसके नोड्स मेटास्टेसिस होने के अर्लियर चांस रहता है, टेंडेंसी रहता है. देन बक्स फेशिया, जो कि एक नेचुरल बैरियर है, टेम्पररी नेचुरल बैरियर है, प्रोटेक्ट करता है कॉर्पोरा को. पेनिट्रेशन ऑफ बक्स फेशिया एंड ट्यूनिका एल्बुजिनिया, तो इसमें कॉर्पोरल इन्वेजन होता है एंड वैस्कुलर डिसेमिनेशन होता है वहां से, जब बक्स फेशिया और ट्यूनिका एल्बुजिनिया इन्वॉल्व हो जाता है। ठीक है, लिम्फेटिक स्प्रेड रीजनल फिमोरल इलियाक नोड्स में होता है जनरली। ठीक है, प्रीप्यूशियल लिम्फेटिक्स एंड शाफ्ट लिम्फेटिक्स, ग्लैंडुलर एंड कॉर्पोरल लिम्फेटिक्स, ये से जाएगा सुपरफिशियल लिम्फ नोड में, जो कि फेशियल अटैक को है सुपरफिशियल, देन वहां से डीप लिम्फ नोड एंड वहां से पेल्विक लिम्फ नोड, जो कि है एक्सटर्नल, इंटरनल एंड ऑब्चुरेटर। नोडल डिजीज में क्या क्या हो सकता है? स्किन नेक्रोसिस, इन्फेक्शन, डेथ ड्यू टू सेप्सिस, इरोजन इनटू द फीमोरल वेसल्स। ठीक है, डिस्टेंट मेटास्टेसिस कॉमन कहां है? लंग्स, लिवर, बोन एंड ब्रेन, 1 to 10% में दिखता है। अभी इवैल्यूएट कैसे करेंगे? तो बायोप्सी लेंगे। बायोप्सी में क्या क्या देखना है? डेप्थ ऑफ इन्वेजन, वैस्कुलर इन्वेजन, ग्रेड, ब्रोडर्स ग्रेडिंग, जो हिस्टोपैथोलॉजिकल ग्रेडिंग है डिफरेंशिएशन बेस्ड पे। देन एससीसी मोस्ट कॉमनली फाइंड हो सकता है, उसमें भी कौन सा वैरायटी? पैपिलरी मोस्ट कॉमन है। अदर क्या क्या है? बेसिलॉइड, कॉन्डिलोमेटस, वेरिकस या सार्कोमेटॉइड। जो बाकी के सारे हैं पैपिलरी के अलावा, ये सब और ज्यादा अग्रेसिव हैं। ठीक है, एंड दे आर एसोसिएटेड विद एचपीवी समटाइम्स। देन पेरिन्यूरल इन्वेजन, जो कि स्ट्रॉन्ग प्रेडिक्शन है फॉर लिम्फ नोड मेटास्टेसिस, मतलब इन्वेजिवनेस बढ़ता जा रहा है। देन सॉरी, पैरानियोप्लास्टिक सिंड्रोम में क्या आएगा? हाइपरकैल्सीमिया विदाउट ऑशियस मेट्स। देन इमेजिंग में हम क्या क्या करेंगे? पेनाइल यूएसजी करेंगे, एमआरआई करेंगे फॉर लीजन सस्पेक्टिंग द कॉर्पोरा इन्वेजन, सॉरी, और अंडर इरेक्शन भी इवेल्युएट करेंगे लीजन को। नोडल बेसिन को हम यूएसजी, सीटी, एमआरआई से चेक करेंगे। क्लिनिकली डिटेक्टेड मेट्स है तो फिर हम पेट सीटी करेंगे। देन विल कम टू स्टेजिंग ऑफ द टीएनएम, पेनाइल कैंसर, TNM staging of the penile cancer. So TIS is penile intraepithelial neoplasia. TA is non-invasive localized SCC, that is a well differentiated verrucous carcinoma. T1, where T1 on the glans it invades the lamina propria. On the prepuce it involves the dermis, lamina propria and dartus. In the shaft it involves the connective tissue between the epidermis and corpora. It could be divided into A and B, where A is no lymphovascular invasion, not high grade lesion and not sarcomatoid, and B is lymphovascular invasion or high grade or perineural invasion or sarcomatoid type. Then T2, where the tumor involves the corpora spongiosum with or without urethral invasion. T3 is involvement of corpora spongiosum, cavernosum. First, in the second is spongiosum, third is the cavernosum. Then including tunica albuginia with or without urethral invasion, and T4 is surrounding structure like scrotum, prostate, pubic bone. What could be the differential? We'll see at the differential in some time. So what are the nodes? Nodal involvement, N1 is the unilateral mobile inguinal lymph node, N2 is bilateral mobile inguinal lymph node, N3 is unilateral bilateral fixed nodes or pelvic nodes. Then M1 is distant mets. Then we'll come to the stage grouping. Stage 1A, stage 0 IS, that is tumor in situ. Stage 0A is TA, T1 TA, that is non-invasive localized SCC. Then 1 is T1A. Stage 2 is divided into A and B, where stage 2A is T1B and T2. Stage 2B is T3. Stage 3 is again divided into A and B, where 3A is N1 and T is 1 to 3, and stage 3B is N2, T 1 to 3. Then stage 4 is commonly, as we know, that it is either T4, N3 or M1 with any number of nodes, any size of tumor without metastasis. So what are the differentials here? That is chancre, chancroid, granuloma inguinal and herpes and TB. So now we'll see the management of penile cancer. So what is the management? For the primary tumor, So we have to do surgery with margins traditionally where we use 2 centimeter proximal margin for partial penectomy. Now it is 5 mm for grade 1 and grade 2 tumor and 10 mm for grade 3 tumor. In suitable cases, that is TIS, TA and T1 with grade 1 or grade 2, no lymph node or distant mets, we can go for organ preservation surgery where the gland sensation and penile length are important consideration. So how we can go ahead? Modalities for treatment will be commonly in surgery we have limited excision, that is Mohs micrographic surgery, circumcision, limited excision of the glands, gland stripping and resurfacing for the tumor in situ, and glandsectomy. Others we have laser ablation, that is CO2 Nd:YAG, topical therapy like imiquimod and 5-fluorouracil, radiation in the form of EBRT brachytherapy. Then brachytherapy could be interstitial or surface mold irradium 192. Then we go for penile amputation, that could be partial or total. Total penectomy with perineural urethrostomy can be done if required. When we do partial penectomy, तो penile stump को हमको try करना है कि it should be more than 2.5 centimeter. If it is not preferable, feasible, then we have to go for total penectomy because it is of no use. Then we have Sir Parsec Gold procedure where we go for total penoscrotectomy and bilateral orchidectomy with perineal urethrostomy. So this is a radical surgery. Then we have Young's procedure, Young's operation, that is partial penectomy and bilateral inguinal lymph node dissection. So now we'll see the nodal management of penile cancer. So cabana is the sentinel node which is above and medial to saphenofemoral junction. Just a second. Sorry for the delay. So now we'll see the management of nodal disease. So clinically node negative disease where we go for inguinal lymph node dissection or DSNB, that is indicated for primary if the primary is high risk. DSNB is the biopsy. Then it is useful for when the primary is high risk where it is more than T2 or it is T1 with grade 3. It has lymphovascular invasion, or more than 50% are poorly differentiated. If DSNB, that is biopsy, is positive, inguinal lymph node dissection, where we go for more than 4 nodes. Okay. And if the more than 4 nodes are positive, we go for pelvic lymph node dissection, that is bilateral. If more than 2 nodes are positive, we go for, and with extranodal extension, we consider pelvic lymph node dissection on the same side. So bilateral inguinal lymph node dissection are performed as it is not possible to predict laterality of the nodal involvement. So we have to go for bilateral inguinal lymph node dissection. Then clinically node positive disease, we have straight directly go to bilateral inguinal lymph node dissection with or without pelvic lymph node dissection as per the finding of inguinal lymph node dissection. If there is delayed nodal presentation, then we will go for delayed nodal presentation, that is inguinal lymph node mets after more than 1 year of treatment of the primary. So if the nodes are unilateral, we will go for unilateral inguinal lymph node dissection with or without pelvic lymph node dissection. And this is considered if it is more than 3 months of surgery. Then we will just go through the flow chart. If the patient is having TIS, TIA and the physical examination of lymphatic is negative, we will just observe. If it is positive, we will go for 4 weeks of antibiotic. If there is presence of lymphatic, that is adenopathy. If it persists, then we will go for FNAC. If that is negative, then we may go for excisional biopsy. Even if that is negative, then we will observe. If the FNAC is positive or the excisional biopsy is positive, so we'll go for ipsilateral inguinal superficial and deep, pelvic lymph node dissection and contralateral superficial inguinal dissection. with frozen section analysis for the lymph node. Okay. And if it is T1A with negative nodes, we'll observe. If it is positive, we'll again go for FNAC. If that is positive, we'll follow the positive algorithm. If it is negative, we'll go for excisional biopsy. Again, if it is positive, we'll follow the same algorithm. And if it is negative, we'll observe. So, in the end, when the things are positive, either FNAC or the excisional biopsy, we go for ipsilateral inguinal, superficial and deep lymph node dissection along with pelvic lymph node dissection. And in case of contralateral superficial inguinal dissection, we'll go for frozen section if possible. And here, what we considered in one physical examination of the lymphatics, that includes not just the clinical examination, but also the imaging studies. FNAC is the fine needle aspiration cytology, as we have seen. Then the third one, where we go for pelvic lymph node dissection, if two or more positive inguinal lymph nodes or external extension is found. That is, we go for pelvic lymph node dissection. So, two or more positive ipsilateral inguinal lymph node or extranodal extension, then we go for pelvic lymph node dissection. That is an important point. Then contralateral superficial inguinal dissection with frozen section. So, it can be alternative is DSNB, that is biopsy at these experience centers, with superficial dissection if compliant, if the patient is non-compliant. And observation with 4 weeks is generally done only in the low risk tumors with clinico-radiological nodes. So, T1B to T4, if on examination of the lymphatics, both clinical and radiological, if it is bilateral negative, then we go for bilateral superficial inguinal lymph node dissection with frozen section analysis. If it is negative, we'll observe. If it is positive, we'll go for ipsilateral deep inguinal and pelvic lymph node dissection. If there is unilateral node positive, which is mobile and less than 4 cm, we'll go for ipsilateral inguinal, superficial and deep, and pelvic lymph node dissection with contralateral superficial inguinal lymph node dissection. If the contralateral is positive, we'll go for contralateral deep inguinal and pelvic lymph node dissection. If it is negative, then we'll observe. If there is bilateral positive mobile lymph node which is more less than 4 cm, we'll consider FNAC. If it is negative, we'll follow the bilateral negative algorithm. We'll go for bilateral superficial inguinal lymph node dissection and then follow it from there. And if it is positive, we'll go for bilateral ilioinguinal dissection, or we can go for neoadjuvant chemotherapy followed by ilioinguinal dissection. And then at last, we'll go for adjuvant therapy. So this bilateral superficial inguinal lymph node dissection which we are going for in the bilateral negative case, we have a point that it is a complete modified dissection with and dynamic sentinel biopsy is even acceptable. So modified dissection or dynamic sentinel node biopsy, that is DSNB, which we are seeing from above, which is a biopsy, is also acceptable. And 3, where we go for pelvic dissection when if there are more than 2 positive inguinal lymph nodes or extranodal extension of cancer, as in here the pelvic lymph node dissection and here pelvic lymph node dissection. Then 4 is FNAC, as we have seen. 5th is here when it is bilateral positive with mobile and less than 4 cm node. We can either go for bilateral ilioinguinal dissection, or after neoadjuvant chemotherapy, we go for ilioinguinal dissection. So both the approaches are acceptable. Then last, that is the adjuvant therapy. It is given for considering more than 2 positive lymph nodes, bilateral mets or external extension, or positive pelvic lymph nodes. So these are the factors which we consider to plan to give adjuvant therapy. So even if there is bilateral node negative, there is increased risk. So minimum procedure we go for is bilateral superficial inguinal dissection. Depending on the HPE, we go for deep and pelvic lymph node dissection. If it is unilateral positive, then ipsilateral inguinal lymph node dissection and pelvic lymph node dissection. Contralateral uh, we go for superficial inguinal lymph node dissection, and we check. If it is positive, then we may need deep inguinal lymph node dissection and pelvic lymph node dissection. Bilateral positive, we go for FNAC. If it is negative, then we follow the bilateral negative algorithm. Then we see the locally advanced disease, where the tumor is more than 4 cm, with or without node are positive, more than 4 cm, fixed pelvic lymph nodes. So these are surgically unresectable lymph nodes. Then we go for either circumcision followed by EBRT to the primary, that is radiotherapy, or we go for induction chemo. If there is no response, we go for palliation with chemoradiation. If there is good response, then we go for surgery followed by adjuvant therapy in the form of radiotherapy, which could be for the primary, where the margins are positive after the surgery, or for the nodal basin when there is multiple positive nodes and extranodal extension is positive. So chemotherapy. So chemotherapy, where we use TIP regimen, where paclitaxel, ifosfamide and cisplatin is used, or we can use 5-fluorouracil with cisplatin. Then we'll just see the inguinal block dissection. So we have standard and modified, that is Catalona. We'll see one and by one in detail. And so the standard inguinal block dissection, the boundaries of the standard full template inguinal lymph node dissection, the area involved is the Dessler's quadrilateral area, where superficially we have the inguinal ligament, inferiorly we have the apex of the femoral triangle, laterally is the medial border of the sartorius, and medially we have the lateral border of the adductor longus. So it's the triangle. Here we divide the GSV, sartorius is transposed to the laterally to provide cover to the exposed femoral vessel. So it is transposed medially to provide the cover to the femoral vessels. Then in modified Catalona, our aim is to decrease the morbidity associated with the standard, because we go for high dissection, high amount of dissection. Then here we have a short skin incision, limited dissection field. We exclude the area lateral to the femoral artery, exclude the area caudal to the fossa ovalis, preserve GSV, and eliminate the need of transposition of sartorius. So in therapeutic inguinal lymph node dissection, nodal involvement is detected on surgery. Then we go for standard inguinal lymph node dissection. So if it is positive, we have to go for standard. If it is not positive, then we may think of modified one, Catalona. So the complications are the injury to the vessels leading to hemorrhage, iliacs or femorals, injury to the nerve, that is obturator, resulting in impaired adduction of the thigh, then flap necrosis, SSI, then seroma, lymphedema of limb, or deep vein thrombosis. So guys, this was all about penile cancer management, and hope you have understood and it will help you revise fast. And see you in next video. Keep studying, keep growing, and please like, share and subscribe, and keep studying, keep growing. Thank you.